for our adult chest pain patients with cardiac origin is going to be 324 milligrams. All right, oral glucose. Oral glucose, otherwise known as oral glucose, if we're going with the brand name. What's our dose for this, if you wanted to put it in the chat? What's our adult dose for oral glucose? Awesome. Yeah, good job. So the adult dose is going to be 15 or 10 to 15 grams of glucose. Typically, it's one full tube. I've only ever seen, I think, one tube that's a multi-dose tube. All the rest of them are what you see on the screen here, and they're the single dose. Now, we're giving this for low blood sugar. Our patients that have low blood sugar need to have the ability to maintain their own airway and keep their own airway safe and open. If they don't, we cannot give them this medication. Okay, so to receive this, they have to be able to be alert enough to maintain and keep open their airway. Now, the reason there's two different ones on here, these are essentially the same thing. This lemon one here and any oral glucose medication is going to be artificially flavored. Now, you'll notice this one, the Transcends 15 glucose. You can get this at Walmart. You can get it at Walgreens. It tastes a lot better. So a lot of ambulance services are starting to carry this one because patients are actually a lot more willing to take the whole tube. But notice here, and maybe you can't see it depending on your screen quality, but it says naturally flavored strawberry, naturally flavored glucose gel. So think critically about this for a second. Why might that be an issue? Yeah, John is on point today. Yeah, allergies, exactly. Exactly. So if we have patients that have allergies to strawberries or allergic to strawberries, we definitely don't want to be giving them this. We could potentially cause an allergic reaction. And if they're calling us for blood sugar issues, they already have enough issues on their hands, so we don't want to cause any more damage. All right, so just keep that in mind if you do carry this brand. Like I said, it's wonderful. It tastes significantly better, so a lot of services do have this, but we just need to be cognizant that there are some allergens in it. All right, one thing I do like to mention about these meds, it's a little bit of a pet peeve of mine, but yes, it does say oral glucose gel. It's oral glucose, but it's not technically an oral medication. Yes, we put it in the patient's mouth, but we don't want the patient to just swallow it, okay? What we want them to do is put it in their cheek and let it sit there and have the sugars in this gel absorb through the mucosal membranes and go straight into their bloodstream. So technically, this is what we call a buccal medication, not an oral medication, okay? Buccal medication. It is okay if patients do swallow this, but that's not the intended purpose. If they swallow it, it has to then be digested and then absorbed through the digestive tract into their bloodstream to then raise the blood sugar as opposed to going straight into their bloodstream. Okay, so just keep that in mind. Oxygen. All right, oxygen, most commonly used powerful medication. This is something we've gone through several different phases of EMS, and thankfully, I think most of you guys are all fairly new into EMS, but it's one of those things we never want to withhold oxygen. There for a while, they were telling us to not give oxygen to specific types of patients that did actually need it, and there was some harm that was caused. So we want to make sure that we're never withholding oxygen. Now, that being said, not all of our patients need 15 liters non-rebreather, high-flow oxygen slapped on them at the very beginning of every single call, right? It's just not necessary. So what we need to do is use our critical thinking skills, look at the patient, look at, the vital signs that we're getting, work of breathing, coloration of the patient, and so on and so forth, and determine what the appropriate amount of oxygen is to give to that patient. Now, with that being said, I'm a firm believer that there's not really a wrong place to start when we start administering oxygen. What's wrong is our inability to think through and reanalyze our patient, reassess our patient, and determine whether or not we need to change something with the oxygen. So for example, if I were to say you guys all go to a patient that is, 73 years old and having difficulty breathing with an SpO2 of 92% on room air. They're struggling to breathe. Their color isn't looking great, right? Yeah. You guys might say, well, we're going to put oxygen on the patient, obviously, but let's say we'll start at 2 liters nasal cannula. Awesome. That's great. Maybe somebody else in the class says, well, we'd start at 6 liters or 8 liters nasal cannula, or maybe somebody wants to put them on a non-rebreather. None of those answers are necessarily wrong. What's wrong is when you reassess the patient and go, okay, we put 2 liters of oxygen nasal cannula on initially. Their SpO2 was at 92% initially. Now it's at 90%. Well, let's just leave the oxygen where it is. No, that's not okay, right? When we reassess and we find that our patient isn't getting better, in fact, is getting worse with the treatment that we gave, we need to up the oxygen a little bit, right? That's when you would go, okay, this isn't doing what we want it to do. Let's bump it up to 8 liters, and we'll reassess what else can we be doing. Maybe there's additional medications that we can be doing, like albuterol or something like that, right? So that's my little kind of tidbit with it, is it doesn't necessarily matter where you start with the oxygen, but you need to be reassessing and turning it up or down depending on the patient's reaction and response to the medication, okay? Any questions on oxygen? I know it's kind of a long-winded response or answer here, but. Okay. Perfect. The next medication is activated charcoal. This is something that you're capable of giving. Technically 1 gram to 1 kilogram of patient, but usually it ends up being the whole tube anyways. I will say this is something I haven't seen in EMS at all. It's never been on any of the trucks that I have ever worked on. Not because it's not a good medication to have, but because there are so few times where it is appropriate for us to be using it, and out of those very few times where it's appropriate to use, the patient isn't willing to take it. So they were finding that there was a lot of waste with this particular medication, and EMS trucks were just taking it off of their trucks. So if you have this on your vehicles, or if you will eventually work for a service that has this on their vehicles, awesome. Certainly you need to know the dose, you need to know when and how to use it, but just be aware that you may or may not have this on your truck. Narcan. So this is a big one. This has been in and out of the news quite a lot within the last, I don't know, 10, 20 years maybe. Naloxone is the generic name, and then we've got Narcan is the specific brand name. I actually don't have a picture of it on here, but we'll see if we can pull one up here shortly. It's technically an antidote for a patient who's unconscious and in respiratory failure after taking an opioid narcotic. Then if it doesn't work, if you give it and it doesn't work, it means, well, okay, I don't like how this is phrased here. I need to change that. But it doesn't necessarily mean that the patient hasn't had a narcotic. It may very well mean that you haven't given enough Narcan. Now, that being said, it's kind of a fun little invisible line that we get to walk, because there is a point where you're giving too much Narcan, and you got to change tactics, all right? So medications, or drugs out there, street drugs, and prescribed medications as well, but any opioid, are getting so incredibly strong and powerful that our standard dose of Narcan is no longer efficient, or effective, I should say. So in those instances, we're finding that we're having to give 2, 3, sometimes 4 doses before it's actually starting to give the effect that we want for our patients. Okay, so I don't like that it says if it doesn't work, they haven't had narcotics. No, not necessarily anymore. It just potentially means that we haven't given enough of it yet. But if you start finding, okay, we've reached 4 doses and there's absolutely no response to this, we need to start thinking down a different path, and maybe we're missing something like, did we check a blood sugar? Is this actually sugar related as opposed to narcotic related or opioid related? Okay, so EMS in general has a tendency to kind of get stuck in one place. We go down this path and we don't always think and try and turn ourselves around with it. So you definitely really need to with Narcan these days. I had a patient in Sparta, Wisconsin, that we would go to their house fairly consistently, and we'd give 2-3 doses of Narcan nasally while we were getting IVs and everything set up, because paramedic service, right? And he never responded to the intranasal Narcan. We always had to give him Narcan IV for it to actually take effect. He needed to have that much in his system for it to actually work. And that particular patient was put on what we call Narcan drips, where your body is constantly getting a steady supply of Narcan for however long. And some people actually get admitted into ICUs on Narcan drips because they have so much opioids in their system and they're so strong that it just takes that much to try and combat them. Okay. Glucagon. So this is a fairly crummy picture of glucagon. It comes in a nice either red, white, or orange case, depending on the manufacturer. I've also seen it where it's just the powder, and it doesn't come with a pre-filled syringe like this. So this is a pre-filled syringe. It's got 1 ml of normal saline in it, and then this bottle here is a 1 milligram compressed powder tablet. So it actually looks kind of like a Smarties tablet. So what you do is you take this out, you uncap your syringe here. There's like a safety piece here on the plunger. You take all those off and you inject the 1 ml of fluid into the 1 milligram of powder. And then you're going to take the medication and either gently roll or gently swirl the powder and solution until it mixes together appropriately. It might be tempting to try and shake the bottle, but we don't want to do that. What that does is creates a lot of air bubbles, and we don't want the air bubbles because then obviously we don't want to inject that into our patient, right? So we're going to sit there and we're going to swirl or we're going to roll the medication until everything is nice and diluted. It doesn't take very long. Maybe 30 seconds, maybe. It's fairly quick. And then you're going to book answer. You're going to take a different syringe, draw it up with a different needle, draw it up, and then give it to the patient intramuscularly. So this has to go into a large muscle group, either in the shoulder, the deltoid, or in the glutes. Okay, either location is fine, whichever is easiest. The reason we don't want to use the same syringe is when you poke the needle into something and take it back out, there is the potential to kind of dull the needle. So when you give the injection, there can be a potential for problems there. Okay. I forgot to mention, this does elevate blood sugar. So this is what we use instead of oral glucose if our patient is unresponsive. So remember, our oral glucose works wonders, but they have to be responsive enough to protect their own airway. If we have a patient that's completely unresponsive, we can certainly give the glucagon instead. The next one is albuterol and Atrovent or ipratropium. So albuterol is one that you were able to have able to give as EMT ones. It's typically it comes in a container very similar to this, and it's got single-use packets inside of it. Each packet has a single dose, and that dose is 2.5 milligrams, 2.5 milligrams in 3 mLs of solution. So 2.5 milligrams in 3 mLs of solution. You would then put that in what we call an atomizer, which is this device, and then blow oxygen through it, and then it will nebulize. Okay. The albuterol is a rescue medication. It works very, very quickly, but it doesn't last very long. It's a bronchodilator, so it kind of opens up all the airways and everything, kind of helps patients breathe, and it works very quickly. But again, like I said, it doesn't last very long, which is why we have the ability to give ipratropium. Ipratropium, Atrovent, same thing, different name, okay? Ipratropium packets are usually green, just like albuterol packets are usually blue. It is dosed very similarly, so this is going to be 0.5 milligrams in 2.5 milliliters of solution. And again, same thing, we'd open this bottle, put it in the atomizer here, and then nebulize it. Ibupropium does not work right away. It's not a rescue medication, so it takes a bit for it to work, but it does work for a very long time. So typically what we'll do is we'll give both at the same time to our patient, so they get the quick-acting albuterol, but the long-acting Atrovent. You can buy these medications packaged together, and when they're packaged together, it's called a duoneb, and typically it comes in like a purple packaging, purple and blue packaging. Okay? As EMT basics, per the state of Wisconsin, you are able to assist with any medication that is already included in a pre-approved route of administration. And the wording in this particular rule is very, very weird. But essentially, you're able to give IM injections, you're able to give oral medications, buccal medications, nebulized medications, sublingual medications is a new one for your level. So any medication that falls within that, you're able to assist with if the patient has already prescribed it. So say your patient is prescribed say metoprolol, right? Metoprolol is a blood pressure medication. It's not one that you are able to just give. But say they're prescribed metoprolol, and you get on scene and they're like, before I go to the hospital, I want to take my medications. I haven't gotten my morning meds yet. Let me take those. But they're having a hard time opening a bottle or something like that. You can go ahead and get their meds out and hand them to them so that they can take them, even though those meds are not technically ones that you're able to administer. Okay, you're still able to assist. We just have to make sure that they are actually prescribed to the patient. Okay, so on that same note, if it's a regular, just over-the-counter medication, technically that rule does not apply to those medications. Don't ask me why, it's the state being the state. But technically you're not supposed to assist with those medications. Now, if it's something like your patient's having an allergic reaction and they're not really sure what to do, it's not an anaphylactic reaction, but they called you and they've got a bottle of Benadryl sitting next to them, and you as a reasonable adult know that, hey, Benadryl would probably really help with this, but they haven't taken it yet. It's not technically prescribed to them, but it is an over-the-counter medication. Technically, you can't give it. I will say, maybe off the books, but I will say it wouldn't be a bad idea to just like say, hey, that Benadryl's for allergic reactions, right? It might not be a bad idea if you wanted to take one or two of those, depending on what the dose is, right? So, like I said, a little bit of a gray area, but we do that. So bronchodilator inhalers are also ones that we can certainly assist with. So these are going to be prescribed inhalers that are specific to each patient. Typically, these little vials on top will come off, and there will be a prescription label on it if it's not already labeled on the outside of the medication or on the plastic piece. So in those instances, you want to verify that this is the correct patient, that the medication isn't expired or anything like that, and it's good to give the patient. All right. Nitroglycerin is another one that we can certainly help with the patient or help the patient take it. Again, it needs to be prescribed to the medication. We can't, oh my gosh, words are difficult tonight, guys. It needs to be prescribed to the patient for us to be able to give it to them. Same thing with EpiPens as well. You can give the patient's EpiPen to them. All right, so this is an image of nitro. This is a sublingual spray. Nitro does come in several different forms. So the spray isn't nearly as common anymore as it used to be, maybe about 10, 20 years ago or so. Now we're seeing more often that it's the nitro sublingual tablets. Terry, did you have a question?
Oh, no. No, I don't. I'm sorry. Was I
Okay,
hitting something
no, all
here?
good. I just wanted to make sure we got it answered if you had one.
Yeah, let me just check, make sure I don't have it raised.
Nope, you're good. You just did unmuted, so I was curious. All right, so back to nitro. So this sublingual spray is 400 micrograms per spray. 400 micrograms and 0.4 milligrams is the same thing. I say that right? Yeah. So the tablets will typically say milligrams on them, not micrograms, but it is the same dose either way. Okay. Okay. So nitro is usually prescribed to patients that have a history of cardiac-related chest pain. What it does is it's a vasodilator. It helps to dilate all of those vessels and allow oxygen to kind of get where it needs to be. We will go a little bit more in depth with nitro and technically all of these medications in the specific PowerPoints where we're talking about those issues. So like we've got a cardiac chapter coming up here tonight. We'll talk about nitro again a little bit more in depth in that particular chapter. Okay. Big contraindication for nitro, and this is one that the National Registry loves to ask questions about. But a big contraindication with nitro is taking any sort of erectile dysfunction medication. Those two different types of medications do work very similarly in the body. They both affect those coronary vessels and help dilate everything. So we don't want to give nitro to a patient that's already taken, say, Viagra, because they work the same, and we don't want to tank their blood pressure. Okay. And that's exactly what's going to happen, is their blood pressure will drop quite a lot. EpiPen auto-injectors. So these can be prescribed to the patient. There's also services that carry auto-injectors as well. I will say it's maybe a little bit more common for services to carry draw-up epinephrine these days. The draw-up epinephrine is the same exact medication. It's just not like pre-filled syringes, essentially, right? You have to physically draw up the medication and then administer it. So it takes a little bit of extra time. But we certainly can give both versions. So here on the screen, we've got 3 different types of EpiPen auto-injectors, or auto-injectors, I should say. EpiPen is a brand, so they make adult, which is the yellow one, and then pediatric versions, which are the green ones. They are the 2 different doses. So adult is going to be 0.3 milligrams. Pediatric is 0.15 or 0.15 milligrams. But the other ones are the same doses as well. They just look a little bit different, made by different manufacturers. So it's kind of the cool thing about these square ones. They're like small rectangles, essentially. These will talk to you. So you take off the safety cap, and it will actually start talking to you and telling you, this is what you need to do next, and this is the next step, and the next step, and the next step, until you actually deliver the medication. So it's really nice for patients that either have never used one before, or maybe it's for family members that have never used one. They're very nice and user-friendly. This is a vasoconstrictor, so it relaxes smooth muscles and airway passages as well, but it kind of constricts all of those vessels back down to the size that they're supposed to be. It does affect heart rate and blood pressure. It's not a true contraindication for us to not give the EpiPen, though. So if we have a patient that's got, say, a heart rate of 130 while they're having an anaphylactic reaction, we're not going to go, oh, we're not going to give this because it'll make their heart rate go up. No, honestly, it'll probably just make the heart rate stay the same, to be honest. When people can't breathe, they have a tendency to have high heart rates, right, because they're freaking out a little bit. So when you fix the breathing issue, typically their heart rate kind of comes down a little. With the epi, it might stay up, but still, it's not a contraindication, okay? Force protection medications. So there's 2 different medications that we give for force protection. One of them is an atropine auto-injector, and it's used to treat responders in the event of like a terrorist type chemical attack. I haven't seen those for a long time, and Mitch is on tonight. Maybe he can comment on this. I've never seen one on trucks. My understanding is that they went through a phase. The government went through a phase for a while to try and get them on every single truck, and then I think things just kind of fizzled out a little bit. But Mitch, can you comment on that?
So it was to counteract any type of terrorist attack nerve agent. You were allowed 2 on the truck. The driver got 1. If you had 3 people on, you basically had to do rock, paper, scissors to figure out who got the second, but the driver always got 1 of them. So that way they could at least get them to the hospital. The problem is nothing ever happened, and now we have all these expired atropine auto ejectors someplace in a warehouse. So they've taken them off the trucks, not using, and suppose somebody said, yeah, they're in a warehouse someplace. The federal government's got them. They're all expired. But that was the logic behind it. If there was a terrorist nerve agent attack, the driver would get a treatment, and then one of the other ones, other EMTs, if they had more than 2. The patient did not get the treatment. This was for the staff or the crew. So, but yeah, I don't know how long ago it's been a while since they've been on trucks. So
thanks, Mitch. I appreciate it.
Yep.
So just some general information about pharmaceuticals. Each medication is listed by a generic name, but they also have kind of 3 different names total, including that generic name. So we've got the chemical name, which most people don't know, the generic name, and then the trade name or the brand name. So Tylenol is one that most people are familiar with Tylenol. Tylenol is a trade name or a brand name. The generic name for Tylenol would be acetaminophen. So oftentimes we're dealing with both the generic and the trade, or one or the other. Even on prescription lists, we'll see either generic or trade names. Oftentimes, if somebody is prescribed a medication, they will usually prescribe the generic version just because it does the same thing, and usually it's a little bit cheaper, especially if the patient doesn't have insurance. So it's something that you should be aware of, but I will say, like, through the process of just working and having multiple calls and looking at multiple different drug lists and so on, or medication lists for patients, you kind of get used to the different names that these medications have. When you're giving a medication, you need to know the indication. So why are we giving it? The contraindications, why wouldn't we give it in this particular situation? Any side effects that might be occurring, and any untoward effects. So I'll use nitro as an example. I know it's not a medication that you can technically give. You can only assist with it, but we will roll with it here. So an indication for nitro would be chest pain. A contraindication would be low blood pressure, or maybe they've taken an erectile dysfunction medication. So you need to check what's their blood pressure, and you need to ask, have you taken any erectile dysfunction medications? Side effects of nitro, it can give your patients a headache. My experience is that if you tell your patient that they might get a headache, your patient is going to get a headache every single time. Again, my experience, but typically I won't tell them the side effects until they tell me that they have a side effect, and then I'll say, oh, no worries, that is a perfectly normal side effect that happens, and then try and make them more comfortable with whatever the side effect is. An untoward effect. So an untoward effect is essentially a side effect that isn't negative. In fact, oftentimes it's just another reason why we want to give the medication. So with nitro, for example, it lowers your blood pressure. Most of our patients that are having cardiac related events have elevated blood pressure. We're talking like 180s, 150s, somewhere in there, right? So even though we are not giving nitro to specifically lower their blood pressure, what we are going to do is give nitro to help with the chest pain, and also it will maybe hopefully bring that blood pressure down to a more acceptable level. Okay, so hopefully you get what I'm saying. It is technically a side effect, but it's not a negative side effect. In fact, it's something that we might actually want to happen. Medications come in several different forms, and being that you guys are in EMT 2 instead of EMT 1, you're probably used to this as well, but we have things like compressed powders or tablets. We've got liquids, gels, suspensions, fine powders, gases, and then those sublingual sprays as well. Administering any medication or assisting with any medication is a serious responsibility. You absolutely need to know the medication inside and out. If you give a medication and then all of a sudden your patient has an additional symptom after you give that medication, you need to know if that symptom is related to whatever is going on with the call, like the chief complaint, or is it being caused by the medication you just gave? Okay, you need to know these medications, absolutely. And then, of course, use good judgment. If there's ever a question as to whether or not you should or shouldn't use a medication, you need to have the judgment to be able to think through that problem and come up with an acceptable answer. Offline and online medical direction. So we always have this at our disposal, essentially, whether it's related to medications or any other medical problem that we're dealing with in these emergency situations. We always have the ability to use our online or offline medical direction. So offline medical direction, we're not speaking to anyone, we're looking at our standard orders. These are our protocols or our guidelines. Every single service out there has a protocol or a guideline. They may call it one or the other, but it's essentially the same thing. It's a very how do I say this? It's kind of an outline of what you should be doing in any given situation. So protocol books are usually very thick because they go through a lot of different, pretty much any common situation that you might come across. And it says exactly what you as an EMT or advanced EMT or paramedic or whoever should be doing on each and every one of those calls. Within those standard orders, it will say, during a chest pain situation, if the patient meets these criteria, you're going to administer this amount of aspirin. Okay, those are your standard orders, your protocols, your guidelines. Okay. Online medical direction. So we're speaking directly to a physician. We're going to listen, we'll talk to the physician, tell them what's going on, we'll listen for an order or a response, and then we'll repeat it back to them. Then we'll ask for any clarification if necessary. So if we've got a patient that, say, has aspirin on their allergy list. Now, there's a lot of people out there that have aspirin listed on their allergy list at a hospital. Typically, it's not that it's a true reaction or allergic reaction to the aspirin. Typically, it's a drug interaction problem. A true aspirin allergy is actually fairly rare. So usually it's a drug interaction problem. Not something we should take lightly, but it is something that is above our scope of practice, essentially. So we would call the hospital or call online medical direction, ask to speak to a physician and say, hey, I've got a patient, 62 years old, has crushing chest pain. We gave the prescribed nitro. I went to give them aspirin, but they said that they have aspirin listed as an allergy because of a medication contraindication. This is the medication based on asking the patient. Are we still able to give aspirin, or would you like us to withhold that until we get to the hospital? They would then say, go ahead, withhold the aspirin until we're able to further evaluate the patient. Or maybe they say, go ahead, based on that medication, you're going to give the aspirin at this dose, 324 milligrams. You would then say, okay, I am going to give aspirin 324 milligrams per your order. They'll say, yep, see you when you get here. Awesome. If we have any questions, we'll ask those questions, and then we'll administer the medication and move on with our call. Okay, so these are always at our disposal, and the conversation goes very similarly if we're asking about medications versus asking about like a treatment or just a generalized question that we've got. Okay. We need to go through the rights of medication administration as well. So do you have the right patient? Is this the right time to administer the medication? Is this the right medication? Is this the right dose that we're giving the patient? And are you giving the medication by the correct route of administration? So do you have the right patient? If you're giving a medication, a prescribed medication, you need to make sure it's the right patient, right? Is it the right time to administer this medication? So Tylenol is a medication that we can give now, right? You're only supposed to take Tylenol, depending on the dose, it's about every 6 to 8 hours. So if they just took Tylenol, called the ambulance, you get there and want to give them Tylenol, is it the right time to take this, or do they need to wait another, several hours before they're able to take a secondary dose? Is it the right medication? So there's certain medications that we have. Epinephrine is probably the biggest one, where depending on which service you work for, they might have varying bottles of epinephrine. So they'll have epinephrine with a 1 to 1,000 concentration, epinephrine with a 1 to 10,000 concentration, and sometimes they'll have epinephrine with a 1 to 1,000 concentration. So when you go and you grab your epinephrine bottle, you need to know which bottle you're grabbing to make sure that it is in fact the appropriate medication to give to the patient. Each one of those, even though it's still epinephrine, each one of those does a completely different thing based on the concentration of the medication. Okay, and there's a lot of different medications that are like that. Is this the right dose? So thankfully, a lot of the medications that we're giving in EMS come in single dose vials, but COVID is a really good example of this. During COVID, supply chains for medications were disrupted heavily, and we weren't able to always go with the same supplier that we typically were getting our medications from. So we would go with a different supplier, while the other supplier might dose that medication differently, or it might have a different concentration. So instead of giving the whole vial, now we were only giving half of the vial. Or maybe we needed to give 2 vials instead. So you need to always verify on the vial or the medication packaging what the dose is, what the concentration is inside of that vial, look at it appropriately, and then figure out what you need to do, okay? And then are you giving it by the right route? I already was on my soapbox today about oral glucose medication, but that one is probably the biggest one, making sure that it is given buccally as opposed to orally. There are a lot of different routes of administration: oral, sublingual, buccal, inhaled, intranasal, intramuscular, intravenous, subcutaneous, intraosseous, endotracheal, and those are all telling you kind of where the medication or how the medication needs to be given. So just backing up here a little bit. So oral is just going to be swallowed. It'll be digested and then broken down in their system. Sublingual is under their tongue. So you'll have the patient lift the tongue and you'll put either the spray or the tablet under the tongue, and it will then dissolve going through their mucosal membranes, hopefully. Inhaled is just being breathed in. So this is like our nebulizers, our oxygen. Intranasals, Narcan, I believe, is the big medication you can give intranasally. So Narcan. Intravenous, you're not able to give any intravenous medications at this point, but that's straight into a vein. Intramuscular is going to be going into the muscle, like glucagon. Subcutaneous is injected under the skin. There's also subdermal as well. So a subdermal injection would be like if you've ever had a TB skin test, that's a subdermal. Subcutaneous, typically they give it like in your tricep. There's not a whole lot, and I don't think there's any actually in EMS that we give subcutaneously. Interosseous medication is given into the bone. So it's very similar to IV, but instead of going into a vein, it goes into a bone. And then endotracheal is going to be sprayed directly into an endotracheal tube that goes straight into the trachea. So again, this isn't a medication type that you're able to give. Pharmacodynamics is a study of effects of medications on the body. What effect will that medication have? How will that medication affect your patient specifically? And any patient-specific factors that might change how that particular medication works. So all of that falls under the study of pharmacodynamics. So not only does knowing the medication really come into play here, but also knowing your patient, knowing what problems your patient has, and anticipating how they're going to react to that medication is huge with patient medication administration. After we administer any medication, we need to reassess the patient for several different reasons. We never know when a patient's going to have an allergic reaction to a medication, so we need to be watching them very carefully, make sure that there's no negative effects going on. We also want to know if that medication worked. Or is it not working? Both of which is very good information. You know, if it's working, wonderful. Is there anything else we can do for the patient? Say you gave albuterol and it's working. Awesome. Maybe we can consider giving them Atrovent as well. Get that longer term effect, right? Or is it not working? Okay, we gave, I don't know, nitro, and it's not working. Okay, did it have any effect at all? Positive or negative? Okay, none at all? Well, what do we need to do to reassess? Maybe we need to give an additional dose, or maybe we need to reevaluate the history of what's going on with this patient. Maybe it's not cardiac related chest pain. Maybe it's respiratory related chest pain or musculoskeletal related chest pain, right? So we need to always kind of be thinking, depending on the reaction of our patient to these medications. This next one, this is Advair. This is a discus. It's a kind of an inhaled medication that patients can take for respiratory disease processes. This is a pretty common one. So this like dark purple piece kind of, actually I think it's the light purple. The light purple piece kind of spins, and then there's like a little mouthpiece that you can put your mouth on and then inhale the medication. They're kind of funky looking, and I haven't seen them for a while, but they used to be pretty common, that you'd see those quite a bit. It seems like, doctors or physicians in the area seem to go through certain phases of, prescribing specific medications, and then they'll switch, and then it seems like everybody is taking a specific medication, but maybe that's just our perspective. But when we ask for medications, we certainly should be asking about any herbal agents, vitamins, or supplements that the patients are taking as well. Here's a couple on here, and I won't read all of these, but if your patient says, oh yeah, I take, garlic, like, okay, I am not expecting you, nor is anybody at the state or the national level expecting you to know why a person would take garlic supplements. If you know, and this is like your jam, and you love herbal agents, that is spectacular. I love that for you. But if it's not, don't worry about it. Just typically the follow-up question would be, okay, what do you take garlic for? And then they would say, oh, high cholesterol, or whatever reason you would take garlic. Okay. Assisting with IV therapy. So again, you cannot start IVs. I do believe in the state of Wisconsin, you can manage IV locks after they're already placed for interfacility transport. So if you go and you have a patient that needs to go from one hospital to the other, and they have a heparin lock, otherwise known as a saline lock, or just a lock, you're able to take that patient from hospital A to hospital B, as long as there's nothing connected to it, and you're not expected to give any medications through it. Okay, but you can care for a patient that has one. You also can help your AEMT and your paramedic partners set up for a IV, whether it's fluid administration or just a set saline lock. Okay. Again, the benefits of giving an IV, giving fluid is a big one. There's a couple of medications that AEMTs and paramedics can give through IVs as well that can be very beneficial. So it's possible they want the IV for one of those medications as well, or just as a safety precaution. Okay. So with the lock, the IV catheter, we call it a catheter, is going to be placed into the vein. And once the needle portion is taken off of the catheter or out of the catheter, the plastic catheter stays in the patient's vein. At that point, typically you're going to put like a saline lock. It's a short piece of tubing. It's only about maybe, I don't know, an inch or two long. Sometimes they can be really short and they're like just maybe an inch long. They're going to put that on the IV instead of tubing or like fluid tubing. From there, they'll kind of put it in place and secure it and all of that. So you may be asked to help gather that equipment and get it ready for your partner. Fluid administration, the process of starting the IV is very similar, but instead of putting a lock on the end of it, typically you would attach IV fluid or fluid tubing. So it's significantly longer. I'm sure you guys have seen them at some point. I think there were a couple pictures in your book, but it's significantly longer tubing, and it connects to a bag of fluid, typically either normal saline or lactated ringers initially. Okay, and it's going to hang above the patient. So again, you may be asked to help collect that equipment and get it prepped and ready to go for your patients. So the clear plastic tubing that comes with fluid bags is going to have something called a drip chamber on them, as well as a flow regulator and a drug or needle port. So this is kind of your standard IV bag here, and his thumb is covering what should be two little kind of tubes that jet out. It's maybe, you can see one right here in between his hand. It's maybe only about a half an inch long, maybe. There should be two of them. One of them is going to be used for medication, to put medication into this bag, and then the other one is going to be where you add your tubing. So this is what your standard IV tubing looks like. You can see it's kind of curled up here, so it's fairly long. This is your drip chamber that they're holding here, and there's a different picture of it coming up. This is the spike, and we're going to use this spike to insert into the bag, at which point it will fill the drip chamber, and then the fluid will flow throughout all of this tubing and all the way down to the very end. This white plastic piece here is going to be the regulator. When it's all the way up, it's open. It's all the way open. Fluid can just flow naturally. When it's all the way down, it's going to be closed. It'll be clamped off. Okay. So when you're ready, you can go ahead and spike this through. This side, the side that's meant to have the spike go through, is going to have a removable cap. The one on the other side, instead of it being a removable cap, is kind of a hard piece of plastic with a little rubber stopper on the end, meant for you to be able to inject into the bag, pull the needle back out, and not have it leak. Okay, but you're going to spike this bag. When I do this, typically, I will close that roller clamp first so that when we spike it in, we don't have any fluid just flowing automatically. I have to be the one that opens it up to then have it flow through. So you spike it in. You want to fill this drip chamber, and again, you would kind of adjust the roller clamp to adjust your flow here. But you want the drip chamber to fill about halfway. The idea is that this is going to drop small little droplets of fluid, and we want to be able to see that. Okay, so we're going to open that up, watch the drops flow. This drip chamber is going to be full, about halfway full, and then we're going to flow fluid through this tubing until the entire tubing is full of fluid, at which point we're going to clamp it off. Okay. You don't really want any bubbles in this tubing. You can have really teeny tiny small ones, and that's okay. That's not really a big issue. But we don't want to have like big amounts of air in this, right? So we want it to be as clear as possible. And you can kind of flick at the bubbles and get them to disappear, or float back up or whatever. All right. So this is something that they should be going through in your skills class, all right? So you guys should be able to get hands-on with these things, or at least pulling out some of the equipment so you can see it. Troubleshooting an IV, this really should be something that your EMT or your paramedic is working on. You really shouldn't be accessing the IVs at all. In general, if the IVs aren't working appropriately, having the patient like straighten their arm out, taking a look at the site, the insertion site, to make sure that nothing is red or swollen, causing massive issues, making sure that those roller clamps are open, so on and so forth. It's kind of the generalized troubleshooting. But again, that's not something you should really be doing because you're not qualified to start these. That really should be on the paramedic or the advanced EMT. All right, that was the end of this chapter. I'm going to go ahead and stop the recording. All right, I believe the recording is stopped. It's about 7:10 right now. We'll come back at